Dr. Max Gomez. You know, it's been 35 years since Louise Brown, the first test tube or IVF baby, was born. And since then, more than 5 million IVF babies have been born. In fact, today, assisted reproductive technology is producing healthier babies with higher pregnancy rates and far fewer treatment cycles. Here's how doctors are doing it. They make a big media splash. Octomom, Kate Gosling, and others having large multiple births. But fertility experts consider these cases a profound failure of IVF because any multiple birth, even twins, run significant health risks.
Twins have twice the risk of dying in the first month of life. They have 6 times the risk of cerebral palsy. They have 7 to 8-fold the risk of other serious complications that involve their central nervous system or intestines.
Carla Keckelrice feared those multiple births with IVF, but she had no choice. 2 ectopic pregnancies had destroyed both her fallopian tubes. So she volunteered for a study at Reproductive Medicine Associates of New Jersey that led to the birth of her son Brandon, and just Brandon.
The study was great because it would give us the ability, possibly, to eliminate having a multiple pregnancy, which was a little scary for us.
The reason most embryos don't result in pregnancy is that they are genetically abnormal, and doctors can't tell they're defective by looking at them under the microscope.
Even in your 20s, as many as 20 to 25% of embryos are chromosomally imbalanced. That number is 85 to 90% by the time you're in your early 40s.
So Dr. Scott and colleagues devised a test to analyze the chromosomes from the part of the embryo that was destined to become the placenta, which is genetically identical to the part that would become the fetus. The fetus is unharmed. That allows a transfer of just one genetically normal embryo, and therefore no multiple births. Better yet, as Carla found out with Brandon, the odds of having a baby with this one embryo technique actually go up.
Those embryos produce a baby, a live-born healthy infant, roughly 2 out of 3 times.
Another related advance that is dramatically improving pregnancy rates with IVF is the discovery that the uterus or womb has to be synchronized with the embryo that's developing in the lab in order for implantation and pregnancy to occur. Turns out that's easier said than done.
The uterus is really only optimally ready to allow an embryo to implant for 2 days out of each cycle. Now, in theory, nature would make that embryo ready to implant at the same time the uterus is ready to receive. But it is not always so, particularly in couples who are having a difficult time conceiving.
So it used to be that if a developing embryo didn't look quite right when the uterus was ready, it was thought that that was a bad embryo and it wasn't transferred into the woman. In reality, that embryo may just have been a little slow in developing and was perfectly viable. Solution?
If they're not in alignment, don't put the embryo back. It is much safer to freeze it, transferring it next month when that alignment occurs again, and you get outstanding delivery rates. We used to believe those embryos were inferior, and we were wrong.
It's the combination of advanced embryogenetic testing that results in single pregnancies like little Brandon, and the ability to freeze embryos for transfer into the uterus at the optimal time that has made assisted reproductive technology virtually as successful as the old-fashioned way of making babies.
We've seen giant increases in our implantation rates, and it's healthier children, higher pregnancy rates, fewer treatment cycles, better outcomes.
Other advances have focused on the precise reasons for infertility and for repeated miscarriages by working out the exact energy metabolism of the egg, the quality of sperm DNA, and how those two interact to make a baby. Seems it's a whole lot more complicated than that birds and bees lecture we all got from our parents. I'm Dr. Max Gomez for Science and You.
I'm Donna Hanover here at Reproductive Medicine Associates of New Jersey. Today we'll meet a doctor who's helped couples have children through gestational carriers or egg donation or both. We'll also meet a couple having their second child with the same gestational carrier who gave birth to their little boy. It's easy to see what devoted parents Rachel and Stephen Klein are to their son Brody. It took them many years to have a baby, even after going through procedures like in vitro fertilization.
I was able to get pregnant a few times, but each time I had an early miscarriage, an early loss.
Reproductive Medicine Associates of New Jersey figured out why.
Basically, I have what's called a unicornate uterus, which is a uterine anomaly. It's like I don't have the whole uterus that you should have. And with that, they suggested that a gestational carrier was probably our best answer. Because we had these healthy embryos. We had even done genetic testing on the embryos, so we knew that they were viable and healthy and strong, and we just needed a better or stronger uterus to put them in so that they could actually survive through a whole pregnancy.
One of the founders of Reproductive Medicine Associates of New Jersey, Dr. Paul Bergh, says medical history is important in a gestational carrier.
They have to have had a child before, they have to have a good obstetrical outcome, a full-term delivery, no complications, no health risks. And then you want to look at the social issues. You want to make sure that she's in a good relationship, that she's a stable relationship, that she's in a nice home and has a steady income, and that she gets along with the intended parent. Because they do actually get very close.
The Kleins interviewed several women and found Kendra, who lives in Oregon with her husband Eric and their 2 children.
And for me also, it wasn't even just about her, it was about her her husband and her family. And he was in the Coast Guard and, you know, was stationed out in Coos Bay, Oregon, which is where they met. And he was originally from Long Island. And I think all of that played into the process in my mind.
Dr. Bergh says medical preparation for the gestational carrier is not difficult.
All we do is give her hormones to simulate a normal menstrual cycle, which is just pills and some injections.
And then comes the embryo transfer.
We had these 10 wonderful embryos. We even knew the sex of them. But
What did you say to the doctor? I want a boy?
no,
Nope.
we actually said we'd like you to choose the 2 strongest embryos. She flies to New Jersey, and we transferred 2 embryos to Kendra. And then a few days later, she goes back to Oregon and takes a blood pregnancy test, and she was pregnant. And it turned out that she was pregnant with 1, and it was a boy.
Why would a woman choose to be a carrier for another woman?
The women who are carriers are just, as a group, are wonderful people. They are caring, they really are into helping other women have families. And it's truly an altruistic mission for them. It is not about the compensation they get for their time and trouble. It really is about giving someone a gift that no one else could give them.
Laws about fertility treatment vary widely from state to state, and intended parents often look for a gestational carrier in states that allow compensation for her and their own names on the birth certificate. So the carrier may live too far for the parents to attend each doctor visit.
Anytime she had a doctor's appointment, we talked right after. She was great about sending us, if there was an ultrasound, she'd send us pictures, or she would always have all her facts from the doctor's appointment. So I rarely actually even followed up with the doctor myself, even though I had that access too.
The 2 couples became very close. For Brody's birth,
We were all in the room. Kendra, obviously. Her husband was next to her, sort of coaching her. I was sort of with the doctor, just front and center, waiting. I actually helped the doctor deliver Brody. What she had said to me was, you know, you didn't get to carry your baby, but how many women can say they actually helped deliver
And I
their
cut the
baby?
cord.
And
unlike the Kleins, sometimes there's a problem with the woman's eggs, so those couples may turn to an egg donor. The donor egg and the sperm are used to create the embryo, which is then transferred into the uterus of the wife or a gestational carrier. The donor may be a family member or someone unrelated who gets compensation.
Egg donors are typically younger women between the ages of 21 and 30, 31, who go through the IVF process, taking fertility drugs that are daily injections. They have frequent ultrasound scans and blood work, and they ultimately go to a minor surgical procedure where the eggs are extracted. So it's about a 2-week commitment. It's actually a lot to go through for them.
And how complicated is the surgery for that?
It's a very simple procedure. The donors have anesthesia. They feel nothing. We put a very small needle into the back of the vagina, into the ovary, and aspirate, suck out the eggs. And it takes about 10-15 minutes.
Using a donor egg means the child has no DNA from the intended mother.
Nobody comes in here asking for egg donation. Nobody. It's always an option of last resort. So it is a big step for couples. But for them, it's more important to be parents. And the DNA and the genetics are less important. You know, it's about who's going to take care of that child, who's going to love that child and raise that child.
The cost of these fertility treatments is high, even when insurance covers some portions.
In New Jersey, there's a mandate that covers fertility treatment, which also includes gestational carrier. But an out-of-pocket expense for a patient who has no coverage can, using her own egg, can easily run $40,000 to $60,000.
And using a donor egg?
A donor egg will add another $15,000 to that price.
When the Kleins thought about having a second child, they didn't have to go through another cycle of egg retrieval because they still had frozen embryos from the previous time. They hoped Kendra and her family would help again.
She did say that she wouldn't have, like, she didn't want to do this for another family. She wanted to do this because she wanted Brody to have the same place.
Would you like a baby sister or a cool car?
Cool car.
Cool car.
Couples looking into having a child through the use of a gestational carrier or an egg donor or both need to be aware that these procedures can be medically and legally complex. But generally, there is a lot of gratitude on the part of couples who have used these options to finally have a family. I'm Donna Hanover for Science and You.